We have heard a lot today about policy issues for healthcare reform, with a particular emphasis on steps that can reform how healthcare actually works, like Medicare paying for value, like infrastructure improvements, including health IT investments that are tied to value, like healthcare coverage reforms that promote these sorts of steps. And we're going to hear now, I hope, about how the politics for these kinds of reforms looks. It seems like there is considerable bipartisan interest. It seems like there is the potential for broad support. We'd like to hear more about that. And we've also just heard a very provocative and challenging discussion around public opinion. Healthcare affordability is the big concern as part of the overall concerns about the economic situation, but it is not really, in the public's mind, connected to the kinds of issues of quality and value and delivery reform that we spent a lot of time on this morning. So what's the process for making that connection? What's the role of presidential leadership? We heard a little bit about that already, but also, importantly for this group, what's the role of congressional leadership? And we've got two outstanding senators to help lead this last panel. First, further on my left, Senator Richard Burr has represented North Carolina in the Senate since 2005, after serving in the House of Representatives since 1994. Throughout that time, he's been a thoughtful and effective leader. I've had the privilege of working with him on a range of issues, including health care reform, public health issues. He's also been very active on issues related to veterans affairs and accountability in the federal government. In health care, he has developed some innovative reforms that can help people take more control of their care, an important goal on our process of getting towards more personalized medicine. He's also led the way on some innovative approaches to foster the availability of better treatments against agents of bioterrorism and other public health threats. Senator Sheldon Whitehouse has been in Washington for less time, only a couple of years, but he's already had a tremendous amount of experience with reforming health care throughout his career. He founded the Rhode Island Quality Institute, something that Carolyn Clancy alluded to earlier. It's a collaborative effort between healthcare providers and insurers and the government to pioneer the use of electronic prescribing and electronic health care to get to improvements, measurable improvements in quality of care. He also served previously in his career as Attorney General and the Director of Business Regulation in Rhode Island. In the Senate, he started out with 3 bills to reform how health care works, including legislation on improving quality and linking payments to quality, and to support a national health IT infrastructure. They're going to be leading the discussion, and as I said, I'm going to be assisted in moderating here by Chris Jennings, a longtime colleague and friend, a more than 2-decade veteran of health policy reform efforts in the Congress, the White House, and the private sector. Chris is currently the president of Jennings Policy Strategy. It's a consulting firm that focuses on affordable quality care issues. From 1994 to 2001, Chris served as in the White House as senior health care advisor to President Clinton through the Domestic Policy Council and the National Economic Council. And now he and I are co-directing the Bipartisan Policy Center's Healthcare Reform Project. This is a project led by former majority leaders Baker, Daschle, Dole, and Mitchell, and I'm pleased that the Engelberg Center is providing a lot of the technical support for this bipartisan effort. Chris, let me turn to you for some initial remarks, then we'll get the discussion going with the senators.
Great. Well, it's a pleasure to be here and an honor to be with two senators I really admire from afar. And I have to say, I had the privilege of working for 10 years in the Senate before I worked in the White House. And I have to say, you can't, the one thing about the White House is the White House proposes, but the Congress disposes. So we're going to have these two leaders really playing an important role if there is going to be anything to get done here. And I'm actually quite excited about the prospects. And if I have a couple minutes, I just wanted to raise a little bit of optimism about the possibility for reform and give some context, and then hopefully in a more general sense, and lay the predicate for a discussion where I think we have two experts here, which is the issue of quality and value. First, let there be no doubt we are in an absolute economic crisis, and with crisis comes opportunity, I would suggest. In this country, rarely do we do anything outside of crisis of any substantial proportions. And I think in this context, clearly there is an openness to greater change. But I think what's very, very different from the time that I was engaged in the last bigger health reform debate in 92, 93, was that the economists who are advising the president see this link between both long-term ability to compete, our long-term care, our long-term fiscal policy, our whole economy, our inability to address costs in healthcare are clearly the fundamental, or one of the fundamental reasons that will indicate whether we can be successful in these areas. And if you look at Ben Bernanke, or if you look at David Walker, or if you look at Peter Orszag, or if you look at Larry Summers, they are all talking about the integration about the healthcare debate within the discussion about strengthening our economy. Secondly, the business communities, large, small, manufacturing, retail, are all very much invested in and supportive of a long overdue and substantial debate on health care. And interestingly, their big focus has been, we spend a lot of money in this thing, but we're just not getting the value that we think we should. And they have become leaders through Leapfrog and a host of other areas of pushing and promoting significant change. There is never a discussion that Mark and I go to where Peter Orszag doesn't talk about the 33% of the healthcare dollar that we spend on goods and services that do not improve quality outcomes. Interestingly, if you apply that 33% to the over $2.1 trillion we spend on healthcare, that equals $700 billion a year. Kind of an interesting parallel number, isn't it? And I have to say that even this issue of the uninsured has started to people are starting to understand that people aren't looking at the uninsured as an issue as it relates to the moral blight so much as the cost shifting that is associated with the uninsured. And they're also looking about the uninsured about how do you, if the real problems of our healthcare system are our inability to prevent and to manage the chronically ill populations substantially well, how do you do that without covering populations in significant ways? How do you do prevention well? How do you do chronic care management well? How do you eliminate cost shifting? So even the debate about the quality value discourse, I think, is increasingly understood to be far more also integrated to our success, at least having some basic health coverage within that vision. And then I think the last thing I'm going to just mention are 2 or 3 quick things. One is the economic crisis does breed an appetite and greater openness for fundamental change in this system. And people are ready for change. People want to see a vision. And here's the most interesting thing, I think, the interesting component of this is that sometimes, and we've learned this in Washington, sometimes incremental is no less easy than comprehensive. You have many more levers to pull when you're talking about the issues related to delivery reform, the issues related to financing, the issues related to coverage, if you put it all on the table. Now, we may not get it all done at once, but I have to say that incremental can be very hard because people start talking about, I really don't care that much about this policy except for the fact about what I'm using to offset or pay for it. And then you don't get much engagement of the various communities. And the last point is this, and I think this is probably the most significant irony of the debate that we're seeing. Notwithstanding the rhetoric by both Senator Obama and Senator McCain during the campaign about the special interest, the truth is that the special interest, or in Washington we call them the stakeholders, they're far more invested in and interested in a broad debate. And I heard Larry ask this question about whether the physicians will be involved, whether the insurers will be involved, whether the pharmaceuticals will be involved. Go through each and every one of those stakeholders, and you will find that they have a fundamental interest in broader reform. The insurers do because they don't want to be scapegoated, but they also see that if they want to play a fair game in terms of insurance reform and guarantee issue and in rating reforms, that they fundamentally need to have everyone covered. The pharmaceutical industry doesn't want to have, again, the scapegoating debates about, direct negotiation or reimportation or a whole host of other things. They're open to broader reforms if it also incorporates broader coverage enhancements, and you can get to a significant balance and compromise. I could go through every single stakeholder in this town, whether they're consumer, business, provider, plan, or pharmaceutical, or other manufacturers, and give you the reason why they want to engage in a substantial debate. And I think the heart and soul of this, though, has to start with where we have this discussion beginning, which is that in the end of the day, we will not be able to afford our current liabilities, let alone those we wish to address in terms of the uninsured, if we don't get better value in the health care that we're providing today and hopefully tomorrow. And with that, I think I'm trying to lay the stage for the discussion we're about to have with the senators.
Yeah. Now, I'm not sure which of you, thank you, Chris, I'm not sure which of you wants to speak first. I know you've
the
been
senior
working
senator,
together on...
the senior senator should speak first.
I know you've been working together
senior
and working with some other Republicans and Democrats on just how we can get health care reform done. You've been putting a big emphasis on reforming the delivery system as part of that. So how's it going to happen?
Well, I think we have, but as it relates to specifically what Sheldon and I have tried to facilitate, we're trying to do the easy things. If you can move the pipes and get a different result, we've been trying to focus on that for the balance of this past year. And I dare say we've made some incremental progress in identifying some things that are easy to change. They don't accomplish what Chris just talked about. And let me play devil's advocate for just a second. I think he laid the typical scenario that everybody who's a stakeholder probably has for some time wanted a robust debate and reform of the healthcare system. What alarms me right now is the AMA is not out with a position. Physicians aren't out asking for something. Pharmaceutical companies basically said, here we are. Go ahead and do what you're going to do. My fear is that the people who have the most at stake have disengaged from the process. And the question is, will they engage in that level of debate? Certainly the platform looks like it's going to be there for debate. I'm a little bit concerned that the stakeholders aren't beginning to position themselves in a way that allows us to naturally move through a process. I think the last time there was something big stuck up, that didn't go over too well because it became purely politics and not a debate about policy. To get to the right type of policy, there is a process. I heard the predictions before we came up for a year from now and where we'd be. Well, I'm going to tell you, with what I'm looking at from a standpoint of the economy, I'm not sure, you can debate other things, but I'm not sure how we digest much more than the economic crisis that we're in. Because at some point you have to look at the funding mechanism. It's either a change in tax law, it's an injection of federal funds, it's a mandate on companies. I can go through the list, all of you know the list. Tell me, how do we fund the reforms in healthcare? I think the goal of where we want to get to is shared amongst all of us. That we know we want to get to a point that the quality is measurable and that it's better, that the cost is reduced by maybe a third. The debate, the policy debate, is how we get there. What tools do we use to measure? Who pays for it? At the end of the day, I'm amazed how we have a tendency to leave beneficiaries out of this process. Because at the end of the day, it's the American people that are going to weigh in. And if we haven't thoroughly vetted the policy side of it, no matter what we've got, we'll come up on the short end. So it really does benefit this process that we have a deep policy debate and that at every avenue we try to include the American people. Now, let me speak from the right for just a second. I'll let Sheldon speak from wherever he's going to go.
The left.
If I had to pick a few common things that I think has to be centerpiece of reform, one, prevention and wellness. It has to be the nucleus of the healthcare system of the future. 2, I think it's safe to say that everybody in this country has to have the resources to either access coverage or to pay out of pocket. We have to significantly change our access points for the delivery of health care. An emergency room has to be there to deliver emergency care for trauma patients and not primary care for people that don't have the ability to pay or who are without coverage. 3, every American needs to have a medical home. We can define through the policy debate what a medical home is. That can be a primary care doc. It can be a registered nurse. It can be a community health center. It can be a rural health clinic. But unless a beneficiary has a medical home, then we will never reach the efficiencies that Chris talked about and that we're all striving to get to, because disease management is an absolute key to our ability to drive the cost of health care down. And the only way to do effective disease management is if you do an education program for patients that can only be done through a medical home. Lastly, I think we can never lose focus of the fact that whatever we do has to continue to drive innovation and breakthroughs. I think there are several designs that you can come up with, but if you stymie the innovation of pharmaceuticals and medical devices and these components that allow us to live longer, allow us to cure disease, allow us to maintain disease, then we will have given up something in this country that others will seize as an opportunity, not just to further society in the countries they live in, but as a driver for economic growth and for investment in the future. So it's absolutely essential that we hold on to the commanding lead that I think we have had in the past, though it has slipped some in the recent decade of innovation and breakthrough. With that, I'll shut up.
First of all, let me thank Mark and Chris and Brookings for doing this. This is an absolutely damned vital discussion to be having, and it needs intellectual leadership, and what you're doing, I think, is very important. I'm particularly honored.
Why'd they invite us?
I know. We snuck in. I'm particularly honored to be here with my colleague, Senator Burr. The group that he's referring to could probably be called the Bookends Club, because it's me and Sherrod Brown and Richard and Tom Coburn. And I would suspect that 90% of the Senate is between us. And nevertheless, we have had very, very good discussions. And as you just heard Richard lay out his top 4 principles, there's not a whole lot that I would disagree with in those. I think that we are at a new place. I think that the entrenchment that was well established politically around the finance and access questions dating back to 93 has been somewhat made a little bit out of date by this whole new discussion that we've had, particularly today, about quality and prevention and delivery system reform. And so there aren't positions that are as hardened there as in the old debate. And I think we're also getting a new sense of urgency that is common on both sides of the aisle. I spent last week traveling to Afghanistan, and the military guys there talk a lot about situational awareness. And I think we're beginning to get more and more situal awareness of what is happening in healthcare. And we've talked about Harry and Louise. Harry and Louise, it's over. This is Thelma and Louise. And we're in the convertible, and it's headed for the cliff. And if we don't do something about it, it's going to get very ugly very soon. Because we only have 2 choices. One is to fix the delivery system and bring it under control the way so many speakers have far more articulately than I could expressed it today. The other is to wait until we get to that, what my chairman on the budget committee calls healthcare tsunami of cost that's coming at us. And we'll only have fiscal tools at that point. We will have throw more people off health coverage. Somebody mentioned that the lousy insurance is a problem. Make it lousier. Pay doctors and providers less per procedure. Do another cut across the board. Or raise taxes to pay for the situation. We're way far down every single one of those roads already, way too far. So the alternative is to redesign the system. And that has one big problem with it, which is that it takes time to let the stuff percolate through. Maybe a decade, maybe 5 years, maybe 15 years. But that really, I think, the situational awareness we need to have in Washington, and that I think is beginning to take hold, you certainly saw it from Chairman Baucus, is that now is the time for us to do a delivery system-based reform that will make those really punitive and harsh fiscal remedies that are our only alternative less likely, perhaps not necessary at all. I'm more bullish than Alice Rivlin was on how much can be saved. I did an incentive-based reform in Rhode Island, which I know, if you've seen the movie The Flight of the Phoenix, you know that they crash in the desert and they have to rebuild a plane from the wreckage, and one of the passengers is an aircraft designer, and they have a lot of confidence in him until just when they're about to take off the plane, they realize, wait a minute, he's not really an aircraft designer, he's an aircraft model maker. So anybody bringing news from Rhode Island has to admit that they're in the business of, being an aircraft model maker. But we have seen how a system reform that is based on incentives changing, that looks into the actual plumbing of how the machine works, so it's not creating all these delays and stalls and perverse incentives and places where the costs get trapped and mount up, you can make a huge, huge difference. So I think that if we do this right, saving a third out of the system is very doable, and over time, perhaps even more. So I'm very, very optimistic, but we do have to look at this as a redesign problem. We do have to look at incentives. We do have to look at process flow, and we do have to look at regulation. And that's where we get to the government discussion that my friend Senator Burr and I are going to have, because government has a very significant role, I think, in all of this. We start with the role of Congress, which I think is to set up some big picture stuff. If I had to define the role of Congress, it would be to put the right question in the right place with the right powers. And if you look out at the landscape of healthcare regulation right now and try to make that adaptation, I don't think it's a fit. So I think we need to actually change the government structure that deals with healthcare, whether it's health feds or state and local quality institutes. I mean, we can get into that discussion later, but that's a very important discussion to have. Congress has to know that its role is limited. We can't be making these decisions. Some of them require too much dynamic flexibility for a Congress. Some of them should best be local so that you can try 10 or 15 different ways and see which moves ahead. But we do have to get it done. We do have to leave an important state and local role. And ultimately, I think this is going to be a fascinating problem that, because there isn't such pre-existing political entrenchment, and because it's so urgent, and because it relates basically this is a plumbing problem, it's a systems problem, it's an engineering problem. It's like, you don't care if your plumber is a Democrat or Republican, you don't care if the electrician is a Democrat or Republican, you don't ask the guy who's tuning up your car whether he's a Democrat or a problem, you ask him, can he get the job done? And I think this is one of those areas where, because it's technical, there's a great chance to have this be a political leap forward into a new era. So that's my 2 cents. That's my story, and I'm sticking to it, Richard. Good job.
Chris, any comments or questions?
Well, I'd like to, first of all, I think Senator Burr's vision is the right vision in many, many ways. And it's exciting that if you don't get the infrastructure right on these system reforms, we're not going to be able to afford our current liabilities, let alone the ones we want to address beyond that. So I think there is an increasing consensus. And one thing I want to give you some hope, because we're part of the Obama party now, is hope. That
Rhode Island's motto, by the way.
It's hope. Okay.
It's hope.
But I think in the past, health reform has been driven as much by fear as by hope. And on both sides, and both sides of the aisle use it in negative and positive ways, and all too often in negative ways. And I really don't care the motivating force, whether it's fear or it's hope. But I have some hope relative to stakeholders, because I do see now, in recent weeks, the AMA, the physician community now are talking about coverage for all in a reformed delivery system. I saw Jack Lewin back there with the cardiologist really taking a lead in saying we should be focusing on quality, and that we, our physicians, should be held more accountable, and there should be some linkage to reimbursement reforms to incent those things. That's very exciting, I think, development. So not only are you looking at the primary care, who, by the way, the family physicians are dying on the vine. If we are going to have medical homes, we're going to have more of them. But you're having some leadership in the specialty community that we haven't seen before. And I think that's also quite encouraging. I've talked to the pharma people in recent weeks, and they want to engage. And the last thing I want to throw on the table is I don't think this is going to be an Obama plan or a White House plan or a Burr plan or a Clinton plan or any plan. It's going to be an American plan. It's going to be a plan that works through the system. And if we don't do it that way, we're not going to have broader investment in this package. It's got to be something that is uniquely American, that reflects many of the priorities that Senator Burr has laid out, and I think it can. And so, for example, the Health Security Act we debated in the 1993-94, no longer is anyone engaged in discussions about small business mandates or mandatory alliances or premium caps or all these things that Donna Shalala and I had to defend before. We're now talking about a very proactive policy that engages everyone and in a thoughtful reform of the system that does, yes, provide and ensure coverage for all, but in I think, an affordable, meaningful, more accountable way. So for all those reasons, I have hope, and I also believe that those who don't engage have fear that they'll be scapegoated. And so for all these different reasons, I think that people are coming to the table. At least I hope you see them as you come back in January knocking on your door, and I suspect that you will.
When the CEO of Walmart and the president of the Service Employees International Union are traveling America hand in hand to preach the gospel of health care reform, you know something pretty big is on the march.
I totally agree.
Senator Burr, any further comments on this? I have one question before throwing it open to the audience.
No, my only comment would be Sheldon, I know better than anybody, the devil's in the details.
Yeah.
And it's very applicable in healthcare. And I think that Chris is right. We could have the window of opportunity open up. The only mistake that we could make on the Hill is not to take advantage of the opportunity. Yeah. So I think we go down this road, and I commend Max Baucus for his white papers. By the same standpoint, I also recognize after reading it that Max has taken everything that's been talked about on the Hill and thrown it into the white paper. 6 pages on the Massachusetts plan and 83 pages on everything else. So it didn't necessarily narrow down where we go. It opened up an opportunity for everybody to play. If that's the way we proceed forward, we have a chance. If we go from the 89 pages, 86 of which is inclusive, down to 6, all of a sudden, I think even Chris would admit that the optimism would diminish greatly. And that's the process we're going to have to figure out how we move forward.
Well, that actually leads to my question, which is as the details start getting filled in this process, one of the things that the last panel, focusing on public opinion, emphasized is that, frankly, the public's not quite there yet. They're very concerned about the cost of health care, but don't quite see the connection or the necessity of dealing with the kinds of issues that we've been talking about this morning, and that could be a part of, as you said, getting the plumbing right, getting much better care from an efficiency standpoint, from a quality standpoint, from a value standpoint. And I wonder if I could push you all on thinking about your thoughts on how that connection can be better made. In particular, Senator Burr, the things the 4 points that you stressed seem like things that the public could really relate to in terms of how you connect the issue of affordability of care with the kinds of plumbing reforms, as Senator Whitehouse said, that are needed. People, I think, realize that prevention is not happening to the extent it should in this country, either for chronic diseases or for wellness in the first place. People realize that often care is being delivered in a way that's not efficient, that many people don't have a medical home or a coordinated place to get their care, and that they are very worried about innovation continuing. They hear a lot about genomics and all these new sciences, but it's not really happening yet to get them better health, and they're worried about affording it. So all of those seem like key ways to connect with the public on the kinds of directions for reform as part of this process of getting the details filled in and getting something done that could have bookended support from you, from Senator Whitehouse, from a broad mix of the Congress with support of the President as well. Any thoughts on how to make this connection with the public?
Mark, let me just point to one thing, and this is something that very early on I brought somebody from North Carolina to our meeting to cover with the four of us. North Carolina had the opportunity to be just like every other state, except the cost of Medicaid, continue to let the population sort of drift as they might from provider to provider, and providers receive less than what it costs to deliver the service, and just look at it and say 50 states are in the same game. They decided not to do that, and they created a program called community care. Basically what it is, after you divide regionally the state up, I think it's 13 different regions, they brought every provider to the table that would be needed to deliver a service. The public health folks are there, the mental health folks are there, the primary care doc is there. 13 different providers, all who were paid $2.50 a month to participate. $2.50 a month to be part of this network. And there's also a caseworker for every Medicaid beneficiary. The caseworker is almost the medical home. The network's really the medical home, but the caseworker decides what they need, and they reach out within the network and they pull it in, and the service is provided. What's the experience? In the first year, the state of North Carolina saved $250 million in Medicaid expense with an expanded enrollment. It was so demonstrative from a standpoint of the savings that we've now gotten a waiver to roll that out to dual eligibles. And my point is this, that you can take the existing structure and on a smaller scale you can reach new efficiencies, better quality of care delivered, working with the tools that are already there. Imagine what could happen if what Sheldon said, which is you change the overall architecture and you allow the flexibility within each local area to design a system that reaches the best efficiencies, the best quality of care. I think we're crazy if we don't believe that employers will embrace that type of system, that we won't influence 49 other states on Medicaid, and potentially, I shouldn't say this, but I'll say it right at the beginning, it may influence what Medicare looks like in the future from a standpoint of what seniors demand the delivery system be like. So I understand just how big this mountain is. We're talking about climate. Part of the reason that it's difficult is we've talked about it for 14 years that I've been here. And we've never approached it from a process standpoint that allowed us an opportunity to bring any finality to it. That's the opportunity that's in front of us, that we've got a lot of people on the sidelines, employers, beneficiaries, providers, saying, now's the time. But we also have a lot of hurdles that are out there that we haven't had before that are going to get thrown in our way. So I guess my last piece of advice, if we're looking to create the perfect, then it's not going to happen. If we're looking to move it down the road in the right direction with some fundamental changes that allow us to assess the effects of what they are, it's very doable.
I think I would phrase the priorities in a slightly different mode than Richard did, although I think there's just two ways of looking at the same thing. I look at it more as there needs to be a technical fix. A health information technology infrastructure has to be built. It is ridiculous that information technology in American healthcare is worse than in any other American industry except the mining industry. We have to have a quality, prevention, and wellness improvement, because those are all areas where, by improving them, you can actually lower cost. And that grid, where it both improves quality and lowers cost, should be central to our focus. But presently, our payment system doesn't allow it to be, doesn't encourage it to be. And the third, obviously, is you've got to fix the payment system. Within those, I think that Richard is right. There are going to be some obstacles. For one thing, when Americans, particularly Americans on Capitol Hill, talk about infrastructure, they're usually talking about stuff that the Romans could build. And we need to try to figure out what the real definition is of infrastructure, and then get that done. Because I think if you have a national HIT platform, the same kind of stuff will stand up on it that stood up on the internet once that became available. You'll have Googles and YouTubes and Facebooks and eBays, and it will be transformative, and the private sector will burst with entrepreneurial opportunity. But we've got to build it first. We did it for railways. We did it for highways. Let's get out of our own way and build it for HIT. But we have to rethink what infrastructure is, and we've got to find a way to manage the CBO problem. Because there's a huge institutional bias that has nothing to do with healthcare that casts a dark shadow on a lot of ideas and a bright light on others, and that is whether CBO decides that they can score them. And Peter Orszag is a wonderful guy, but he should not be our healthcare emperor. We have to figure out a way to work the policy forward in a way that makes policy sense. And for some of us who are pretty deficit hawks, it's going to mean, taking a leap of faith that it will, in fact, pay back without waiting for CBO to make the move. And I see those as two big kind of institutional obstacles that we need to work through.
Let me add that we pulled CBO in very early into our discussions, and Sheldon and I only had one question of CBO. How do we do this in a way that you will score a cost savings? We're still waiting for the answer.
They take it into a temple, and they take some chicken bones, and they burn incense, and they put on their robes, and they come out with their decision.
If what we're doing does not achieve a health savings, then why would we do it? So the last gauge, the last gauntlet that we have to run in policy is a gauntlet that's going to tell us automatically across the board, that's going to cost you. It doesn't save you anything. We know it saves us. I mean, I can point to the inclusion of all the uninsured having the resources to access coverage. And I believe everybody in the room would trust me in saying it will save us $200 billion a year in cost shifting in the system just by doing that one thing, because now you have ended that emergency room cost shift that starts. We don't know where the $200 billion is, but we know it's there, and it doesn't go for the delivery of care. That ought to be an automatic red flag as to where we run and try to eliminate that right off, because we know that there's significant savings. And if you just turned around and pumped that back into the delivery of care, you have affected potentially the quality or the outcome.
And fundamentally, the thing that brought our Bookends Club together was the desire to be willing to hold hands and make that leap of faith, irrespective of what CBO said, when we had convinced ourselves and were willing to try to convince our colleagues that this just makes sense and we don't have the time to wait. There's a real sense, I think, of time. I have a real sense of time urgency. We can't wait. We have to design this right, or better, and just start moving. And that may mean jumping ahead of CBO where we need to, and trust our judgment. We got elected to bring our judgment to this task.
Interesting. And there is more coming from CBO soon, so I think they have been listening. Questions from the audience? Yeah, Zoe? Microphone.
Hi, Zoe Baird, Brookings trustee and Markle Foundation, and a great admirer of Mark's work. My question goes up a level. How willing are you, as this debate plays out, to leave it to the agencies, Medicare, CMS, VA, and to the private sector to design their own changes in delivery system models. And I ask that because, but let me just ask you to think at least for 5 minutes about it. I mean, one thing we know Congress isn't very good at is designing business models. And if Congress is going to be picking between the medical home and these other business models, why should we think that Congress could get it any more right than they did with the reimbursement system we have? And if 50% of spending's private sector, are there ways to structure incentives? And I guess I'd conclude the question with just asking you to look back at the financial rescue package and our inability to, the fact that we had the flexibility in that bill for Treasury to change its mind on exactly where it went into the market was obviously tremendously important. And so I just wonder whether part of the mix could be and allowing some differentiation by agency, private sector versus government, that kind of thing, and putting that into your package instead of Congress trying to figure out the new business model.
I think it's less important that Congress answer all the questions than that Congress understand what the questions are, make sure that someplace there is an appropriate locus of decision to address that question, and make sure that that locus of decision has the powers that it needs to go forward. In Rhode Island, years ago when I started the Quality Institute, we brought the Keystone, Michigan intensive care unit reform to Rhode Island to go statewide. And the hospitals were, okay with the idea, but they said, look, you got to understand our problem. We can do this. It'll probably cost us $400,000 per intensive care unit per year. We think we might save $8 million per intensive care unit per year, at which point I interrupt, ignorantly and say, well, great, 20-to-1 payback, go. And they say, no, you don't understand. That $8 million comes off our top line. And the $400,000 comes out of our very scarce cash flow. And at the bottom line, there's really very little benefit to us for doing this. When we understand that problem, which is one of the fundamental problems of the quality failure we're having, then we can set up the right mechanisms to get it addressed so that when a hospital is willing to invest in quality improvement, it sees a reward for that. And there are a lot of different ways to get to it, but I think the most important thing is we've got to have, as I said earlier, we've got to have situational awareness about what our problem is. Once we do that, some of the stuff actually is pretty simple and straightforward, and I agree with you. I don't think Congress should get right down into the final details. We obviously have to set some parameters, but I think it's some basic kind of institutional plumbing shifts that need to take place, and we need to set it up so that they're empowered to do it and that the system is transparent enough and responsive enough that people have confidence in it and that confidence is rewarded.
Let me add one thing. Trying to figure out where we go in the future, one has to understand how we've done it in the past. And for the last 2 decades, Congress has gotten a little more specific in the language of health care that they've passed, primarily because friends at HHS or CMS or wherever might have interpreted a little bit differently than what the legislative intent was. And it got tweaked, by them, and the present company excluded from that. But Congress every 2 years got a little more specific so there wasn't as much leeway for an entity to understand it differently than what Congress envisioned they were doing. And now we're talking about something exactly on the opposite end. We're talking about creating the architecture and letting the things fill in.
Architecture is a good word.
The private entities and the public entities have to figure out in this new architecture how to do what it is they've been doing. If we prescribe it, I would predict to you today the outcome would be worse.
Let me also make one brief argument for a little bit more scope around the whole concept of governance. I think we're coming out of an era of governance that has been fundamentally medieval, in which how true is your faith and how close are you to the bishop were the two things that made the difference. We're having kind of a mini re-enlightenment now, and I think we should have a little bit more confidence that if government is directed towards actually problem solving, that properly directed and appropriately transparent, there's actually a lot more capacity there to make right decisions than we've experienced in the last 8 years. And it's going to take a little bit of actually seeing that happen to get our confidence back. And everybody remembers that the best and the brightest weren't the greatest, but still, I think that there is room for more confidence around governance than we've been entitled to in the last so many years.
Yeah.
I'm Bill Coleman. I'm a lawyer in town. I tried this once before, and people laughed at me. I'll try it again. I think that part of the problem is that our major universities don't do what they ought to be doing. By now, there should be at least 10 major studies on the whole program. And what should be done with the problem? That's submitted. Then the insurance companies come and criticize it, and you get something done. And I felt the same way about the tragedy of the banks doing what they did to put it. I just can't imagine why the great universities no longer do that. In my day, I'm the oldest person in the room, that's what they did. A lot of the New Deal good stuff came out of the fact that first professors worked on it. It was changed greatly, but that really gave you somebody who didn't have a vested interest by either belonging to the insurance company or somebody else.
That's why we have Brookings.
Well, we're getting a lot of help. Larry Lewin and Gail Walensky, and then I think we're going to be out of time.
As I listened carefully, this has been an excellent panel. They all have been. This is also provides a little more hope, and I hope your bookends get filled in with more like you. But there's a kind of a paradox that emerges. On the one hand, the need to move quickly, and the conventional wisdom that if you're going to move, you better do it in the first 100 days because your half-life is short when you're president in terms of your... On the other hand, Chris and others have talked about the need to build a consensus to get the right people around the table. So what's the right answer here? Do you think there should be an effort to very quickly develop something, or given the financial crisis, should there be a Dole-like a council that spends a year or a year and a half trying to pull the key parties in? What would be your recommendation to the White House on how to play this?
I'm new in town. Richard, you go. You've been through more of these than I have.
Well, let me add to Bill Coleman's question, if I could, for just a second. Academia is still very, very important. But academia today is focused as much on the delivery of care and the training of the next generation of healthcare professional, and I think less concerned with how to study the redesign of the system. And probably one would have to get into higher education funding to understand why their models changed, and it's more collaborative with the private sector than it is from the historical academic approach. Larry, I guess if we had the answer, we'd be out proposing it right now. Sheldon and I have the realities of knowing that, legislation usually happens by immaculate conception in the United States Senate. You wake up one day, nobody knows where it came from, but the chairman and the ranking member are for it. So that's not necessarily the process that you need for a major restructuring of our health care. It's my hope that the four key individuals, chair and ranking members, will reach out and try to put together some type of working group to do this. I don't want to suggest to you that it's going to be done in 100 days, and I would hope that we're not here a year from now saying, gosh, I hope we get this group together. I would hope that something were established, it would begin to filter through. We may get at the end of this process and find out, geez, we've got Republicans here and Democrats here. Don't think that's what's going to happen. Certainly possible. We should know that sooner rather than later so that we can still begin to lay this out for the American people. The congressional piece, the Hill piece, should be easy in comparison to the piece where we go out and take it to the American people and begin to sell what we've come up with. That's going to be the much more difficult thing. And I think we're going to get into a level of complexity on healthcare policy that it's not like you're going to have 300 people on the Hill wanting to participate. The pool is rather small from a standpoint of those that understand the intricacies of it that deep.
I think in terms of the timing, President-elect Obama's goodwill will last far more than 100 days. So I don't think that's as important a day.
Say 100 years?
100 days, maybe 100 years. I do think that the next sort of indisputable milestone is going to be the next set of elections 2 years from now. And as important as this issue is, 100% of the members of Congress and 1/3 of the members of the United States Senate are not going to want to have to start campaigning in that year, having done nothing on health care. So I think that's really the window. I think we've got, a year and a half to really wrap this up. I hope sooner, but I think the real pressure is going to come on when we have to go back to the American people and they say, hey, come on. Gail?
The question will extend the thought that Larry was just raising and also some of the comments you've been making. When you look at the challenges of Medicare, it goes to so much of the specificity that's come out of the legislation that the Congress and frequently the administrations have helped create. Everything we've been talking about today in terms of improving value moves in a different direction without having that kind of specificity. There's so much agreement among people in this room and others who have worried about this issue about the directional changes. What do we need to do to be helpful to you so that the Congress gets away from the micro-specification that seems to have been the hallmark since 1983 in the prospective payment, the first of the prospective payment acts, and leads in a way that is necessary for Congress without getting into all the micro areas that get us to a relative value scale where the best physicians practicing in the most conservative way take it on the chin every time because of the inconsistencies in that legislation.
I think that what Richard said about architecture sort of is the answer. My sense is that when Congress has nothing big to do, it'll go out and do little things. And particularly if nobody in particular is looking, then delivering this for that group and this for the other group. And the Medicare system, you can sort of, nobody really notices. And so over many years, that's been the way we've gone about it. If you change out of that mode and say, look, we have to fundamentally reshape the architecture of the system so that there is an adequate HIT platform, so that the dollars go where the value is, and so that we get the quality and prevention improvements that are cost justified and health justified, then a lot of other stuff, I think, begins to fall more into place. But we have to be put into that problem-solving mode, which means I think presidential leadership is very helpful to put the pressure on us at that level. I think the other thing is that I get the sense that if we all sat down and had a discussion in this room, we would all agree pretty much on what the goals are that we need to achieve. The next step, I think, is to take those goals and consider how we get to them. What are the changes in the architecture that need to take place? That's where there isn't much consensus yet among the people who are looking into healthcare's future. That's the consensus that I think that we need, because I worry that the day comes when the Obama administration, some political person in the White House who's saying, healthcare is over, now we've got to go on to the next thing, move that train. If we haven't got our house in order on quality reform, on prevention reform, on reimbursement reform, on HIT, it's going to be awkward to say, no, stop the train, hold it, we have to work harder. They'll say, no, we got the finance and access stuff figured out. We've been fighting about that for years. We know how to solve it. Let's just go with that. We'll deal with the rest later. So I think the more quickly we can come to agreement on exactly what the health fed looks like, what duties go where, then we can move, I think, very rapidly and effectively. And that's what I would hope people would focus their attention on. We can talk to each other about the importance of health information technology till we're blue in the face. How are we going about incenting its growth? Where should the power lie? How do you govern that institution?
Let me just add to that. if the two of us could do it, we could get this done very quickly.
It's the rest of government that's slowing us back.
Yeah. Murder's still illegal, so that's not an option. We have to make sure that the ideas that we think merit public exposure are aired and vetted, and hopefully we try to get those to be the winner at the end of the day. To some degree, that means I think we're going to work outside of the typical committee structure on some things, inside sometimes. I don't see this as a product that just comes out of one committee. I think it's a product that's a collective product that comes together from committees on both sides of the Hill, and I wouldn't expect there to be total consensus. And there will be a process after that. I think that the important part is getting started and sort of stating what our objectives are. Now, I go back to this architecture and flexibility. We did give it to the Secretary of Treasury. Some suggesting today, geez, we shouldn't have given as much flexibility. I've even written a letter to the Secretary questioning not his actions, the need for him to qualify why. And I was on the phone at 9:40 last night with Secretary Paulson begging me that he had to get off the phone. His wife wanted him off the phone, I think, and we were talking about it. We understand that when you create a model like this, it requires a tremendous amount of commitment on our part to go back and make sure that it's filling in a way that's beneficial to the ultimate goal of what we envisioned. And that doesn't mean that we're not going to learn new things. We are. We're going to find out things that work better than maybe what we had visualized.
We got institutionalized.
But you can't walk away from this after you create the architecture and say, geez, we've done our part.
Thank you. Chris, any quick final comments?
No, I just think I was going to say that there's two quality bookends here who are going to write a good book in the next year or two, and I want to thank them for being here. So thank you very much.
Thank you, Chris.
Thank you both. Thank you both. Very quickly, 3 final comments. We've run a few minutes over, and I appreciate our panelists taking a little bit of extra time. First comment is that there's some material in your packet about the Engelberg Center for Healthcare Reform. You're going to be hearing more from us on many of the issues that we talked about today, on measurement, where we're providing infrastructure for a national effort to get to better patient-level measures of outcomes and costs, on reimbursement reform, where we're collaborating with Dartmouth and engaging in some other multi-stakeholder projects around the country, including with North Carolina, where they're now hopefully getting close to getting Medicare involved in that project as well for duals and even more broadly. We're working on some consumer initiatives, including with Jim Guest and others, to help give people the kind of information they can use to get to better decision making. We're working on medical innovation with some collaborative steps, including with the FDA and with the private sector, on more efficient processes for developing and getting personalized treatments to patients. And in putting this all together on coverage reform, events like this are very helpful. We're also working with the Bipartisan Policy Center on a broad effort for a healthcare reform framework. More information about us is available on the website at brookings.edu/healthreform. So that's point number 1. Point number 2 is I want to thank all of our panelists today, Senator Burr, Senator Whitehouse, but everyone from the earlier panels who made such a difference. Many of them have stuck around, and if you have any further questions for them, hopefully you can catch them afterwards. And I also want to thank all of you. The dialogue with participants from the audience here made a big difference to the quality of this event. Final point, number 3, we're not done yet. More to come, both from us and hopefully from you all working together to get effective health care reform done. Thank you all very much for joining us today.